Excellent. So I'm going to talk about endometrial cancer care by the gynecologist. We talked a little bit about endometrial cancer earlier today, and I'm going to try and show you where we are and probably raise some controversial issues about who looks after endometrial cancer. My disclosure slides. Endometrial cancer is an increasing problem. It's because the population gets older and it gets bigger. And you have this problem, I have this problem, and if you look at this Canadian statistics here, the body of uterine cancer here was fairly stable, and then over the last few years it's gone up, and it goes up by 2.6% every year in Canada. So that means for all of us in gynecologic oncology, this is a big part of what we do. And we have problems dealing with all of these patients. There's about 5,600 cases in Canada. It's the fourth commonest cause of malignancy in women after breast, lung, and colorectal disease. Ninth commonest cause of death, and it does occur in young women. I've seen women in their 20s with endometrial cancer. We know that the risk factors, obesity, whether you are just overweight or massively overweight, it increases your risk. Diabetes, probably because of obesity is a coexisting factor. It's obesity that drives this, and extra estrogen from your peripheral conversion of androgens to estrogens. Tamoxifen does increase the risk if you've got breast cancer, and unopposed estrogen slightly increases your risk. HNPCC is hereditary non-polyposis colorectal cancer, and there's a big increased risk with that, so you have to look at the family history. If you want to decrease your risk, you can ovulate on a regular basis, you can have multiple pregnancies, so that's how some of your patients are protected, and early menopause and smoking are protective factors. We talked about this earlier, the good prognosis factors, the endometrial disease, and the others, the uterine serous, the clear cell, the indifferentiated, they have poor prognosis. Some people call this type 1 and type 2. And if you talk about grade 1, grade 2, grade 3, you can see that grade 1, grade 2, and grade 3 have differing amounts of solid tissue, whether that be less than 5% for grade 1, 6 to 50% for grade 2, and greater than 50% for grade 3. We talked about staging earlier, and I'm going to just say that the 2009 staging system did simplify things and make things simpler because it put the old 1A and 1B together in 1A. So if you've got an endometrial cancer that is less than 50% myoinvasive, that ends up being a stage 1A disease. And it also simplified cervical involvement in that cervical epithelium involvement is no longer considered a high-risk factor. It goes back into the stage 1 disease, but then you have to have invasion of the stroma of the cervix to be a stage 2. If you look at some old data from my center, you can see that the survival for overall for stage 1 is very good. Stage 2 survival at 5 years does come down to about 80%, but that would often be treated with radiation as well. And stage 3 about 70%, and stage 4, when we did this in about 2000, there was no survivors at 5 years. I can tell you there's survivors at 5 years now with that. And grade correlates with survival as well. Grade 1 does very well, grade 2 doesn't do as well, and grade 3 has an overall 5-year survival of about 80%. So I'm just going to bring all these slides up. We talked about this as well. You need to, postmenopausal bleeding needs an evaluation. Tissue is the issue. Cancer may be the answer, but you need tissue to make this diagnosis, and the first thing should be doing an endometrial biopsy. In the office, a lot easier than taking them to the operating room. A Pap test, if not done recently, but a Pap test is not a diagnostic test for endometrial cancer. If you can't do an office biopsy, even with misoprostol or other techniques to soften up the cervix, that's when you probably might need to go to ultrasound, plus or minus hysteroscopy and DNC. And we talked about how accurate the biopsy is. Remember that a typical endometrial hyperplasia or AEH, up to 40% of these will actually have cancer on their final biopsy, on their final specimen. So if you actually follow these patients and don't treat them initially surgically, 30% of them will get cancer eventually. But if you take them to the operating room straight away, you'll find cancer in up to 40% of those patients. So AEH coexists with a grade 1 cancer a lot of the time. I've seen patients diagnosed with atypical hyperplasia. They've gone to the operating room and they've had a stage 4 endometrial cancer. So always, if you can, operate on those patients. If you can't operate on them because of some factors, you might need to treat them medically. You should be able to identify grade 3 serous cancers, clear cell cancers on the endometrial biopsy. If you have a doubt, if your pathology is confusing and that's how it's read, have the pathology reviewed. A lot of what I say has to be individualized for where you work, and you should adapt your practices to the local referring center, because you have to work closely with your referring team. Everybody varies about how much radiation they use, how much chemotherapy they use. So you've diagnosed it, or you've diagnosed hyperplasia, consider a pathology review. If it's a grade 1 cancer, they need a chest x-ray. They probably do not need, unless you've got something strange on examination, they do not need an MRI or a CT scan of the abdomen and pelvis. They then need a hysterectomy and BSO, and I'll get to something about who does that later on. But for the most part, for a grade 1, may not need an oncologist to do their surgery. That's where you have to apply for the local rules. Local rules apply and trump everything else. If they've got a grade 2, if they've got a grade 3, if they've got a serous cancer or a clear cell cancer, or there's some concern on the biopsy, they should be referred. If they're unfit for surgery, they should be referred. If they have obvious metastatic disease or unresectable disease, they should be referred. This patient is not somebody you want to do it yourself. This was a patient I operated on a year and a half ago. She was in hospital, she was immobile, she has a pannus that is down to her ankles. And so we had to get that out to operate on the patient. She had a BMI of about 80 or 90, so it was a challenging operation to get that pannus off. You can see where we've marked a belly there, that we're going to get it off. So. And you can judge by the number of towels that are underneath the patient how difficult it was for the anaesthetist to intubate the patient, because she was just, anyway, it was a challenge. So why do we stage the patient? Well, we stage them, hysterectomy, both tubes and ovaries, plus or minus lymphadenectomy, because we want to decide on the extent of the disease. We want to decide whether they need adjuvant therapy or not, so that we can give them some prognostic information, and we can say that we've done the best for the patient. We want to compare our results from center to center, and it's very difficult in the endometrial cancer world to truly compare, because around the world different things are done. In the US there'll be a lot of lymphadenectomy done if it's accessible. In the UK there's not much lymphadenectomy done. Is there a benefit of lymphadenectomy? We'll get to that in a second. You could look at MRI to look at depth of invasion preoperatively, and there's some centers that do that. So if you have a grade 1 with a deep myometrial invasion, you could then refer those patients on for lymph node assessment. That might be something people want to do. Again, a local practice. You can assess the depth of invasion at the time of OR by opening the specimen, looking at it grossly, and for a grade 1 you can usually predict it. That's what I do, but then you have to be able to do the lymph nodes. So if you're a generalist, there's probably not a lot of benefit for doing that, but that might be one reason why the generalists do that. But why the gynecologists and oncologists do that. So as I said, just because FIGO describes HIST, BSO, and node does not need all cases need staging. You can do it laparoscopically. 15 years ago, we were arguing whether you could do laparoscopic hysterectomies or laparoscopic assisted vaginal hysterectomies or robotic hysterectomies. You can do all of those, and they are just as oncologically safe. So you have to decide if you're going to do nodes, are you going to do it as part of your practice for your grade 1 disease? You should do it for your grade 2s and your grade 3s and the serous disease. You should do that. But for the overall risk for grade 1, it's about 3% for pelvic nodes and 2% for periaortic nodes. And thus far, there's no information that lymphadenectomy improves outcome. It's supposed to be a typo there again, sorry. Janice Kwan, who is from BC, British Columbia, she looked at data from Ontario, and they looked at data from women, 316 women from 96 to 2000, mean age of 62, and they did all people that had proper surgical staging. She saw, in that setting, there was a 23% adjuvant therapy usage. There was a fair amount of adjuvant therapy usage, and they saw that risk of death was increased with invasion greater than 50%, cervical stromal invasion, older women, and grade 3 tumors. She then looked at this data here, and I'll try and explain it. So people that had positive pelvic nodes obviously had a poorer survival. However, they looked at the risk factors, and if you were node positive and you had 2 or 3 risk factors, your survival was bad. If you were node negative, which is the blue line, and you had 2 or 3 risk factors, your survival was bad. So some of those risk factors that were inside the uterine specimen predicted who was going to behave poorly. Remembering, all of these patients had lymphadenectomy. If you were node negative with node positive with 0 or 1 risk factors, you actually did very well, treated with radiotherapy. And you were, if you were, I presume some of those were treated with radiotherapy. If you were node negative with 0 or 1 risk factor, you did very well. I look at this data and I say, well, look, perhaps we can look at some of the prognostic factors from the specimen and avoid lymphadenectomy, some of those grade 1 cancers, and look at this and then treat those that have 2 or 3 risk factors present. Remembering the risk factors were invasion greater than 50%, stromal invasion, age greater than 16, and grade 3 tumor. So those are all high risk factors going into this. And so she's just shown that there is perhaps a way of sorting this out without doing a lot of lymphadenectomies. So there's a role for adjuvant therapy, and who of your patients that you operate on need to be referred? Well, I think you should probably, my personal belief is that everybody should go through a tumor board, and there should be discussion with the management for most of these patients. And that way everybody's educated, because if you see 1 or 2 endometrial cancers a year, you do not know who is going to get adjuvant therapy, because you're not keeping up with the data and the trends that's going along.
2 minutes.
Okay, I'm running out of time. So we have some data from old trials looking at survival for radiation therapy, the GOG-99 trial, that didn't show any survival advantage, but showed that there was an advantage for local regional control. Similarly with the PORTEC trial, they showed that there was no survival advantage, but there was an advantage to radiating for vaginal control. Having said that, most of us would look at some of the factors and say, well, overall for a stage 1 disease, we do not need to irradiate the patients. We can wait and see if they get a recurrence and then irradiate them, and 70% of those will be salvaged. We also look at, argue about what is high-risk disease, and the grade 3s, the stage 1Bs, the stage 2 disease. And some of these, another trial here showing that, that there was no advantage of radiation. The PORTEC 2 trial did show that brachytherapy, if you were going to use radiation, brachytherapy and whole pelvic radiotherapy were equivalent for local control. So who needs radiation? There's no improved survival, there is better pelvic control, less vaginal recurrences, but vaginal recurrences are usually salvaged. For high-risk situations, those that are more advanced, you might need to use radiation. And what we look at that is we combine that with chemotherapy, because if radiation hasn't improved survival, you probably have to use chemotherapy to improve survival, to treat that distant disease that might kill the patient. So in the GOG-122, they looked at whole abdominal radiotherapy versus adriamycin and platinum, and the chemotherapy arm had improved survival, but they got recurrences in the pelvis and the abdomen. If you're going to use chemotherapy, what regime do you use? Well, we had a fellow on elective from British Columbia recently, and basically we're going to use gynosilin. Gynosilin is a new regime, similar to penicillin, but it's carboplatin and Taxol that you use all the time. We only have one regime that we use for first-line therapy, and we use carboplatin and Taxol, so it's usually you've got to get gynosilin. In this whole drug trial, they used all different regimes, and they didn't see any difference in outcome, and they they used, so most of us will use carboplatin and Taxol for endometrial cancer, high-risk disease. We're going to, so a practical approach that I've adopted in some of the provinces, it's a grade 1, stage 1 disease, hysterectomy, BSO, possibly one set of washings, although that's not in the staging system. A grade 2, grade 3, clinical stage 1, hysterectomy, pelvic nodes, consider periaortic nodes. Clinical stage 2, you could consider radical hysterectomy, although they're usually going to get radiation afterwards. Clinically advanced disease, individualize the patient, but THBSO and debulking. And the clear cell and serous disease need a full staging if they are obviously stage 1. And then for adjuvant therapy, stage 1, no high-risk features, no further therapy. Stage 1, high-risk features, you can get ideally put on a study, brachytherapy, chemobrachytherapy for probably the grade 3, stage 1C disease, and stage 2 gets whole pelvic radiotherapy, and the higher stages, ideally we put in a study, although we are increasingly putting these patients on sandwich therapy where we're giving them 4 cycles of carboplatin and Taxol, some whole pelvic radiotherapy, usually not with brachytherapy, and then 2 more cycles of carboplatin and Taxol. That's what we've adopted recently for these patients. And some of the stage 4 we'll just give chemotherapy alone to. We talked about follow-up. There's no role for PAT test. There's no role for CAT scans in follow-up. You can just examine the patients clinically and consider a chest x-ray around the 3rd year for the isolated lung nodule. I don't do it regularly, but I also do consider it at times. See them to 5 years, and then I usually kick them out from clinic. So endometrial cancer is common. It will be increasingly in your practice, same as it is increasingly in my practice. You need to carefully evaluate the patient and work closely with the gynecologist oncologist in your referral center about how you're going to manage these patients. And that is the most important thing, is to talk to the people that you're going to refer to and come to some sensible conclusion about how you're managing those patients locally. Thank you very much. Just a quick note, if you want, I based a lot of mine on the SOGC/GOC guidelines. They're available on the SOGC website, and there's 3 documents there about rational where we are presently with treatment. So if you want to get that, that's a good resource to get that from. Thank you.